Health and the Human Services Policy Committee to order. I note that we do have a quorum. The first item on the agenda is approval of the minutes from January 25th, 2023. Representative Frederick, have you reviewed the minutes, and would you like to move the minutes?
I have, Mr. Chair, so moved.
All right, Representative Frederick moves the minutes from January 25th, 2023. Any questions or amendments? Hearing none, all in favor of approving the minutes from January 25th signify by saying aye.
Aye.
Opposed? Motion carried. The minutes are adopted. Members, we've got 3 bills on the agenda for today. One we will take action on. 2 of them have not been introduced yet, but they will be informational hearings so that we will be ready for those bills when they come before us. At this point in time, our first bill we will be hearing will be House File 585 from Representative Klevorn. Because Representative Klevorn is not a member of the committee, I will make the motion to refer House File 585 to the Human Services Finance Committee. Welcome to the committee, Representative Klevorn. If you'd like to go ahead and explain your bill, and then we'll go to the testifiers.
Thank you, Chair Fisher and members of the committee. We have had many conversations over the years about a shared goal to increase access to the services that support older Minnesotans and individuals living with disabilities and complex health needs to remain living in their home and with their own families as long as it is possible. This goal is now more important than ever given the strain on our congregate care settings are facing. House File 585 is a bipartisan effort written in conjunction with the Minnesota Home Care Association. It contains specific and concrete steps we can take to move in this positive direction. The bill proposes a collection of changes aimed at moving the medical assistance reimbursement rates for underfunded home care services and activities closer to being the actual cost of providing these services. The changes proposed in this bill will start to move us towards a more sustainable system of access to home care services. This is a critical piece of our work as a state to better support older Minnesotans and individuals living with disabilities and those with complex health needs to remain living independently. The bill proposes 3 changes. First, it updates the reimbursement rate for homemaker services to address the current extremely low wages that can be paid under that critical service. Second, it establishes a second reimbursement rate for a limited annual number of care evaluation visits, recognizing the actual cost required to do those care evaluation visits. And lastly, the bill requires the Minnesota Department of Human Services to work with the home care stakeholders to identify a care coordination reimbursable service aimed at recognizing at least a small amount of the care coordination work currently being performed by home care staff without reimbursement. I would like to thank Representative Keel and Chair Knorr for joining me as co-authors on this bill. I would also like to draw members' attention to the letters of support for the bill sent to the committee, as well as highlight the governor's inclusion of a portion of this proposal in his recently released budget. The proponents of the bill have been in communication with DHS about the bill for over 2 years and will continue their work with DHS on technical assistance for the bill as that is available. With me today are 3 testifiers who will speak to the need of this legislation and how it will help increase access to home care services for Minnesotans. And with that, Mr. Chair, I would ask for you to recognize Kathy Messerly, the Executive Director of the Minnesota Home Care Association.
Welcome to the committee, Director Messerly. Thank you for being here. Please introduce yourself and start your testimony.
Thank you so much, Chair and members of the committee. My name is Kathy Messerly, and I'm the Executive Director of the Minnesota Home Care Association. We're a statewide association representing home care agency members who provide hands-on care to older Minnesotans and individuals with disabilities in their own homes. Thank you for the opportunity to testify today in support of House File 585 and the changes it proposes to increase access to home care services across the state. The changes in this bill focus on nursing, rehab therapies, home health aides, and homemaker services, all services provided in the individual home. I'll go into a little bit more in depth. Thank you for Representative Klevorn for mentioning the three components. So first, it establishes a new reimbursement rate for a limited number of care evaluation visits. This change is aimed at implementing a reimbursement rate closer to the actual cost that providers incur for three specific kinds of home care evaluations. All three of these visits are required, and they're more comprehensive than a typical home care visit, which is the current reimbursement rate that it's set at today. This involves a more thorough assessment that takes 2 to 3 times as long as a typical visit. Service plans are developed or revisited and adjusted during these evaluation visits. The three specific qualifying visits are, first, the start of care, visits required at the start of a new mode of care to develop the service plan. Secondly, recertification visits. Checks are required every 60 days to ensure everything is going well and according to the service plan, and to make any modifications to the plan. And lastly, resumption of care visits. This is required if there was an interruption in the plan of care to check to see if any updates need to be made. An example would be the patient getting admitted to the hospital for more than 24 hours and then returning to the home. Secondly, the bill directs the Minnesota Department of Human Services to collaborate with interested stakeholders to identify new or existing billable medical assistance services for home care coordination activities. This section of the bill is aimed at recognizing at least a small amount of the care coordination work currently being performed by home care staff without any reimbursement. Examples of care coordination activities that the home care staff carry out include reaching out to a pharmacy or a doctor for additional guidance when there are questions about medications, ordering additional supplies for the client, calling and getting orders from a doctor when it appears additional supports may be needed, and more. The additional reimbursement would only cover time outside of patient visits, time for which providers currently are not paid. Finally, the bill restructures the reimbursement rate for homemaker services to be more reflective of the current market data. Homemaker services are critical but often overlooked services that help an individual manage cleaning and household activities, enabling them to remain in their home. The current rate for homemaker services varies, depends on how the service is accessed, but it is a very low rate that does not allow for a livable wage to be made. Many agencies, unfortunately, have discontinued offering homemaker services because they simply cannot hire anyone at such a low wage. Our home care service providers around the state tell us time and again how the low medical assistance reimbursement rates make it extremely challenging to pay a sufficient wage to recruit and retain home care staff. This translates into more and more waiting lists for individuals who need the services. A growing number of Minnesotans without access to home care services are turning to more intensive, expensive, and currently overstressed facility-based care, such as hospitals and long-term care facilities. Our state can and must do better in providing older Minnesotans and those with disabilities and complex health conditions the supports they need to live full lives. MHC is grateful to have 2 individuals here today to testify about the challenges they're facing due to the current rate structure to ensure clients have access to care. I ask for your support of this bill, and I'm happy to address questions.
Okay. Thank you for your testimony. We'll go on to the other testifiers, and then we'll go to questions and comments at that point. Next on the agenda, I have Sarah Skorberg. If you'd like to come forward, introduce yourself, tell us who you're with, and begin your testimony. Welcome to the committee. Please introduce yourself.
Hi, Chair and members of the committee. Thank you for the opportunity to testify today. My name is Sarah Skorberg. I'm a licensed social worker, and I'm a care coordinator at Thomas Allen, Inc. In my role, I work with Minnesotans who are 65 plus and live with various disabilities and mental health diagnoses. I work to support individuals' ability to remain independent in their communities as they age, by assessing their eligibility for in-home services and helping them make informed choices about their end-of-life care. Thank you for the opportunity to testify today in support of House File 585, specifically the portion of the bill that would restructure the reimbursement rate for homemaker services. While the current reimbursement rate for homemaker services varies slightly depending on how a person is accessing the services, it is across the board a very low reimbursement rate that makes it very challenging for service providers to be able to offer a livable wage. As a result, access to homemaker services is greatly limited for Minnesotans with disabilities and older Minnesotans, meaning they often have to turn to more expensive services and at times have to move out of their homes and communities and into congregate settings. I've spent many hours scrolling through provider lists, consulting with my coworkers, and calling agencies, often being told that the staff that they have available for homemaker services are unwilling to work at the current homemaker rate and take on new clients, or that they do not have any staff available. I've been in my current role since September 2022 and have yet to see a client on my caseload be successfully set up with homemaking services. I'm finding that as I meet with clients for the first time, they mention that they have been recommended for homemaker services but don't understand why they have not received help. I find that they have usually been sitting on a wait list for many months and that they just didn't know it. I've also had a handful of clients lose their current worker and go without services because a new one cannot be found. I have a client who is 95 years old and lives with her son, who provides personal care assistance and homemaking services to her. Her son continues to tell me that he can't pay his bills on the current rate, even though he provides nearly full-time paid care to his mother, and that he's burnt out on his job. I continue to try to provide him options for finding a worker through an agency, but there are none available. I worry about the quality of care that she's receiving, the effects on her family's well-being, and how much longer they might have to wait for a worker to be provided. When clients cannot rely on in-home services, they often go without assistance or their families scramble to meet their needs. And this is just one example of how this service access issue is affecting my clients and older Minnesotans across the state. This is something that percolates my office space regularly. We share frustrations that our clients continue to go without services, we worry for their care, and we feel helpless as providers who regularly see these gaps in care that we cannot easily change ourselves. If we as a state value supporting older Minnesotans and those with disabilities and complex health needs to remain living in their own homes and communities, and to avoid accessing more intensive and expensive care, we must address the access barriers to services like homemaker services. The proposal in this legislation to align homemaker reimbursement rates to be more reflective of the actual cost of providing the service will help increase access to this critical service and support more Minnesotans to live in their own homes and communities for as long as possible. Thank you again for the opportunity to testify today.
You're welcome, and thank you for being here. And if you'd like to have a seat again, I will call up the next testifier, and if we have questions, we'll go to those afterwards. The next person I have is Susan Morgan. If you'd like to come forward, please. Good afternoon. Welcome to the committee. Please introduce yourself, who you're with, and start your testimony, please.
Thank you so much, Chair and committee members. My name is Susan Morgan, and I am the Chief Operating Officer at ACRA. And I thank you so much for the opportunity to testify today regarding House File 585. ACRA is a nonprofit organization founded 30 years ago to focus on the underserved. Our mission is to improve lives by providing support to clients who may be chronically ill or disabled. Our services are available in all 87 counties of Minnesota, helping people to live their best life in their own community. At ACRA, we see every day how the underfunding of various home care services and activities impacts those Minnesotans who are in dire need of these services. I'm a registered nurse who has worked in the home care industry for over 40 years. For the past 20 years, I've worked both in public health and now for a nonprofit company called ACRA Care. Both of these entities primarily serve clients who rely on care that is reimbursed by their medical assistance benefit. The section of this bill proposing an update to the reimbursement rate for homemaker services is crucially needed. Over the years, I've seen that homemaker service is commonly the first home care service that a client needs. As a body declines, these homemaker tasks become more difficult to manage independently. Unkempt homes with loads of laundry undone and dishes stacked high, attracting all kinds of vermin, was something that we regularly saw at Public Health when investigating vulnerable adult cases. We would often refer these individuals to homemaker services. Years ago, the reimbursement rates were adequate to attract and pay the staff to provide this type of work, but that is no longer the case. The homemaker rate lags behind a reimbursement rate that an agency needs to be able to offer homemaker staff a livable wage. If we cannot staff this simple but needed service for our clients, it only results in more admissions to congregate living, which under Medicaid is far more costly. In addition, home care agencies have for years absorbed the high cost of starting or resuming care for a client in the home. An RN must do an in-depth evaluation visit, which can take 2 to 3 hours in the home, as well as another 2 to 3 hours of documentation once back in the office. This is done to comply with state and federal standards of care. We are reimbursed for those visits no differently than a regular home visit that may take up to an hour for the visit and the documentation. And as you can imagine, it's very challenging to make this service work when money is lost on these in-depth evaluation visits. The section of this bill proposing for a separate care evaluation reimbursement is aimed at finally addressing this challenge. Another task that home care agencies are not reimbursed for is care coordination. This involves advocating for clients in many ways. It might be to track down necessary equipment or medications that a client was not sent home with from the hospital. Another example is realizing that a client is in need of better nutrition, so you need to make arrangements for them to access Meals on Wheels. Or attending a care conference in the home with the family when it's time to consider moving their family member to a place that can better meet their needs. None of this is currently a service that an agency can bill for, and yet they do the work to assure that the clients are well cared for. However, it is these unpaid services that limit providers' ability to meet the community need for home care services. The section of this bill calling on the Department of Human Services to work with interested stakeholders in identifying possible reimbursement mechanisms for a portion of these care coordination activities would be of great help. The Minnesota Home Care Association has, for a number of years, brought forward reasonable proposals to help increase access to needed home care services for Minnesotans. Decreasing these barriers to home care access is now more important than ever, as more and more Minnesotans are growing older, and our congregate care settings are becoming more and more overly stressed. I ask for your support for this proposal to help more Minnesotans across the state get access to the supports they need to remain living in their own homes. Thank you so much.
You're welcome. Thank you for your testimony. Committee, we are now open for questions or comments. Are there any questions? Representative Edelson.
Thank you, Mr. Chair, and thank you, Representative Klevorn, for this bill. I think it's so important. It's funny, some of the things that I think lawmakers should go and work in these fields sometimes, right? As I'm looking at just the care coordination activities of what should be reimbursed and what shouldn't, and how it all works, and making sure and you have to come before us to make this happen. And I'm sure you've been probably coming for years on this bill, is that right?
That's right.
And in the meantime, people are not getting reimbursed for this because we're not getting the job done. Well, I think it's really important. I think this is a great bill. I guess the one thing on page 9, when you look at 9.6 to 9.13, it's looking at that care coordination activities may include. I guess what I want to know is the people that you're caring for, were they consulted in making sure that these are the things that they also feel like it's going to be enough? How did you, I guess, Representative Klevorn, I don't know if it's you or some of the members that you have testifying.
I would like to ask
Klevorn?
Thank you, Chair Fisher. If Ms. Meserly could come back to the table, I think that would be the best.
All right. Director Meserly, if you'd like to come back. And Director Meserly,
Chair.
go ahead.
So your question was whether or not we've consulted with the folks doing the care coordination?
Representative Edelson.
Mr. Chair, my question was if patients, if the people that you're caring for, if they were consulted. I mean, I know that this is probably, I guess, if you're owning one of the home care services, you kind of come up with this. Is this kind of the exhaustive list of what you are sure you need, and that when it's managing documentation, supporting transitions, managing medication, were there other things that, was there like a survey done for the people that you're caring for, I guess is what I want to know.
Director Messerly.
Chair, Representative Edelson, there was not a survey done. These are required services, required coordination of care that they would be doing, so we did not do a survey.
Representative Edelson.
I think, Mr. Chair, that's it. I guess I would love to chat with you online to see kind of what your ongoing process of reevaluating these things look like.
Okay, very good. Representative Chair Knorr.
Thank you, Mr. Chair. I don't know who will be able to answer this question. It's page 5, line 5.3, subdivision 16. So the question about rates established by the commissioner, this references the 256S21 up to 256S215. Maybe nonpartisan staff can help us understand what that rate framework is and how will that be, funded.
Certainly, Chair Knorr. I would look over to our nonpartisan staff to figure out who would be the best to answer that. Staff person Punelli, thank you.
Mr. Chair and Representative Knorr, I believe you're asking about the elderly waiver payment rate methodology.
Chair Knorr.
Mr. Chair, Ms. Punelli, yes. And at least this also includes CADI waiver, BI waiver, and the other waivers, CAC, included in that list.
Ms. Punelli.
Mr. Chair and Representative Knorr, currently those waiver services that are listed have a rate phase-in. There was a change in the rate methodology a few years ago, and what was done is most of the rate is still based off of the old rates. I think about 81 or 82% is still based on the old rates, and only about 18 or so % is based on the new rate methodology. So I think what this is doing is it's changing that. So for home delivered meals, I think it's getting rid of that phase-in. And it's also making some other service rates exempt from that phase-in.
Chair Knorr.
Thank you, Mr. Chair. Thank you, Ms. Punelli, for the clarification. I think there's more looking into the phasing and rate frameworks and all that, how it intersects with how we do the funding for some of these programs. Thank you, Mr. Chair.
You're welcome.
Thank you, Representative.
Any other questions or comments? Hearing. Oh, Representative Keel.
Thank you, Mr. Chair, and Representative Klevorn. I appreciate having been involved in this type of service. It is not that I worked it with anybody. I do unpaid help for family, which is fine. It's a reward in itself. But my point is that it's a very visible help when you're not expecting to see somebody struggling with something and you're doing dishes, or you see that they're failing in being able to care for themselves. And so I always wonder about the people who don't have families that can observe, oh, there's a problem here. Because often if you are having trouble with your laundry or your dishes, you're often having more trouble with something else health-wise. So it's an important issue. I would say that we have a problem. I don't know as we're going to hire people for it, because we're having a hard time hiring people for all kinds of things. But it is an important service. It would do well for a college student to look for this to be one of their jobs when they're, going to school. But anyway, I just wanted to reiterate that this is an important service. So thank you.
Thank you, Representative Keel. Representative Klevorn, I don't see any other questions. Any closing comments?
Well, I would just like to say thank you to the committee for letting us have this bill heard today. It is a bill that is truly about having dignity in one's home and having the ability to continue living in one's own home as long as possible. And as Representative Keel, you have said to me before, this impacts everybody, no matter what stage of life you are in or where you live across the state. And I appreciate your compassion and your appreciation for that need. And whether you're in the Twin Cities or out in greater Minnesota, this is something that we all need to consider. Thank you, and I ask for a green vote.
Thank you, Representative Klevorn. I renew my motion to refer House File 585 to the Human Services Finance Committee. All those in favor say aye. Aye. Opposed, say nay. Motion carries. This House File 585 is on its way to the Human Services Finance Committee. Thank you, Representative Klevorn, for the presentation, and thank you to your testifiers for being here today. Our next item of business will be to hear from the Department of Human Services on a couple of their policy bills. As communicated previously, we'll be considering the language of these proposals. We don't have the bills officially introduced yet, but because we know they're coming, we've got the language here. We wanted to start getting the information out so that everybody would have an understanding to get a chance to get their minds wrapped around it. And then when the bills are introduced, then they will be coming before us for official action. So there will be no action today. But if people have comments, questions, et cetera, this is a great time to bring that up so that when they come up for official presentation, if there's a need for amendments or anything, that work can already be started. So I want to say thank you, everybody. I know that the person that will be carrying the bills will be Representative Edelson. We do have Director Grami from the Department of Human Services here. So we're going to start with the first bill. It is marked SC 9961. It does not have an official number yet. Representative Edelson, is there anything that you'd like to say before we hear from Director Grami?
Thank you, Mr. Chair and members. This bill really, I just want to point out, has two policy provisions. 9961 does, which would allow people access to substance use disorder treatment without having to first go through a county or tribal placing authority. And the second provision, and there's many other pieces which I will let the department speak to, but the second provision in this is related to a grant that was passed in 2021 called the Home and Community-Based Services, which is the HCBS Workforce Development Grant. The main change in this provision is the addition of language that would ensure that when direct support professionals receive a payment, they are not inadvertently bumped off of their benefits. So with that, Mr. Chair, I will pass it over to the department.
Welcome to the committee, Director Grami. Great to have you here again. If you'd like to introduce yourself for the record and start your testimony, please.
Thank you, Mr. Chair. Christy Grom with the Department of Human Services. Thanks so much for giving us an opportunity to walk through these bills in advance. I think it'll be helpful to get members familiar with them and to make sure we're answering questions and being transparent. I know department bills can be a little bit big, a little bit technical, and so we want to make sure we're getting you the information you need ahead of making decisions on these. So I want to thank Representative Edelson for being our champion on these two policy provisions. So this first bill, where are we, 9961. So the first provision is related to the Home and Community-Based Services Workforce Development Grant, which is a grant that was passed by the 2021 legislature as part of the Home and Community-Based Services federal medical assistance percentage that we received in 2021. And so this is a grant that primarily is being spent on direct support professionals, so people like PCAs or people providing waiver services to older adults or people with disabilities. 90% of that funding needs to go directly to that workforce to be able to pay for retention and recruitment of those direct support professionals who are in really critical need, as members have been hearing. And so one of the oversights on this bill, which we should have caught in 2021, was that because some of these workers are so low income, they're at 200% of the federal poverty guideline under law, they might be participating in some of our public benefit programs or Minnesota Care. We do have research and surveys that show that some of our DSPs, unfortunately, because their wages are so low, are relying on those important benefits. So we just want to make sure that we're adding exemption language so that this income that they would be receiving as a part of this grant doesn't go against their benefits, and they can continue to maintain, childcare, Minnesota Care, or whatever program they might be using. The other part of this provision is changing the federal poverty guideline requirement from 200% to 300%. So at the end of 2021, when we were working very quickly to figure out the guidance on that HCBS enhanced FMAP, how to implement it and how to get a bill across the finish line, we wanted to really make sure we're targeting the money at the lowest income workers to direct it where it is needed the most, but we do feel now that we can bump that federal poverty limit up a little bit to 300%. So that would go to, I think, single people, it's around $40,000 a year or so of income. So that is the first provision in this bill. And the second provision is related to what's called direct access. And for members who don't know, direct access is a substance use disorder treatment reform that began probably about a decade ago. And one of the things that's a little bit different about the way people access SUD treatment funding in Minnesota compared to other services is that they had to go through a placing authority, so either a county or a tribe, and they would go and basically get what was called a Rule 25 assessment, that might sound familiar to some of you, and get assessed for treatment services, and then the county or the tribe would say, this is where we think you should go to treatment, and this is the kind of treatment you need. Over the years, we've had ongoing conversations with stakeholders, with CMS, with experts around that process really being a barrier to people accessing SUD treatment quickly when they need it. And so we've been working for several years to transition away from that kind of placing authority process to what we call direct access, where if I have a cold or something and I need to go to the doctor, I don't have to call up the county and ask them where I can go or what kind of treatment I can get. I just go to a clinician that I know where I want to go in my neighborhood or whatever and get the services that I'm eligible for. And so that direct access reform happened. It started with sort of a parallel process where people could still get a Rule 25 or get what was known as, the new assessment is called a comprehensive assessment. And that started a couple years ago. And as of last July, so July of 2022, it's fully implemented. And so we can no longer do the Rule 25 kind of placing process anymore. We don't have the federal authority to do that. We were maintaining a waiver from CMS to limit people's choice of provider, and we no longer have that, and CMS was not interested in extending that. And so this direct access proposal is by and large updating cross-references where we've repealed parts of rule and we're putting definitions into statute instead, and making sure that we're connecting to all of the right places in law, making sure that we're removing references to placing authorities or Rule 25 assessments, or they were called, I think, chemical health assessments in law. And then kind of the more substantive part of this proposal is making sure that we're taking the risk criteria that assessors or that clinicians would use when they were doing a Rule 25 assessment to guide them on what kind of treatment services a person would need, and that we're putting those into statute instead to make sure that clinicians out in the field are able to have some kind of guidelines around how to authorize those really important substance use disorder services. And I will say one last thing. We do probably have an author's amendment coming up on this in the next, when this is officially heard. And we've been working with stakeholders both on the mental health side and the substance use disorder side to take a deeper look at our comprehensive assessments and understand how they relate to diagnostic assessments, and really make some streamlining changes so that people with co-occurring disorders or dual diagnoses can more efficiently get access and assessed for the services that they need. And so in the upcoming author's amendment, I just want to flag, there are quite a few changes that we're hoping to make. They're all policy changes to really make some flexibilities and streamlining to improve access even more. And really to work towards those integrated care models that we've been striving for.
Okay, very good. Are there any questions or comments that people would like to make on the file before us, SC 9961? Chair Noor.
Thank you, Mr. Chair. Thank you so much, Representative Edelson, for bringing this bill forward. One quick question that I have is the subtraction and also exclusion from the Minnesota state tax. So I'm assuming that is included, but it does not apply to the federal income tax for sometimes where people get confused. Is that correct?
Director Grau.
Mr. Chair and Representative Noor, I'm not certain, to be honest. Taxes is not my area, although I aspire it to be. So I would probably need to come back to you to just confirm. I don't want to give you incorrect information. I will say this is going to go through taxes so that they can vet it as well. But I can follow up with you on that.
Chair Nort,
Thank you, Mr. Chair. Appreciate it. Thank you, Mr. Graham.
any other comments or questions? Seeing none, we will close the discussion on the language on SC 9961. Next thing that we'll move on to will be the next one that we have in front of us, and that would be SC 0014-1. Once again, this is one that Representative Edelson will eventually be carrying, and Director Graham is here. And we also have a testifier that will be on this one. So first of all, we will start off with Representative Edelson. Any comments that you would like to make?
Thank you, Mr. Chair and members. So the 0014-1, this is a DHS policy bill that makes changes related to disability and substance use disorder services. Most of the changes are technical. There are a few provisions that make more substantive policy changes. We'll focus on more of our discussion in those provisions today. There are 7 main topic areas in the bill language. And I'm going to actually let the DHS just go ahead and speak to them a little bit more.
That's a very good decision there. I will, Director Graham, if you'd like to go ahead and start delving into making this a little bit more understandable for us. Thank you.
Thank you, Mr. Chair and members. So I think what I'll do, given that we have some time, is maybe try to walk through chronologically each section and provide a preview so that everyone feels really comfortable with what's in each section, because it's not always apparent when you're looking through the bill, right? So, and I'm happy to, Mr. Chair, if this is too long, we can kind of speed things up.
Go ahead.
Okay, yes. So starting with the first 13 sections, so sections 1 through 13, beginning on page 1 and then going through page 9. So this is a technical fix. It's correcting terminology. So last session, there was a recodification of long-term care consultation assessments, or those are also known as min choices, and we were changing some terminology around what the support plan is called. And inadvertently, when the reviser made that change, they made some changes around targeted case management and some of the terminology there. And that doesn't line up with what's in our state plan or what's in our policy. And so really, sections 1 through 13 are just reverting back all of those changes that the reviser made in targeted case management around terminology. And then sections 14 through 16, so beginning on page 9 and moving through page 15. So these are several clarifications regarding the corporate foster care moratorium area of statute. And in large part, some modifications were just things that were missed. Over the years, we make a lot of changes in this area of statute, and so just some clarifications here, but also one change related to the repeal of Chapter 144D, which was the Housing with Services chapter, which was repealed as a result of the assisted living licensure that was effective, I believe, in August of 2021. And so essentially, we are, for that particular provision, which is a little bit more substantive, just clarifying that that certain settings, not child foster care settings, are eligible for corporate foster care moratorium exceptions, and making sure that the intent is sort of continues to align, that the law aligns with intent, and that older adults, 55 years of age and older, can get access to those exceptions when they need corporate foster care in those community residential settings. Moving to section 16, so beginning on page 13, line 14. This deals with allowing DHS to grant a variance to permit dual licensure of more than one service class. And so this subdivision, when you take a look at it, outlines which dual pairings are permitted, but it inadvertently omits community residential setting licenses. So this is a newer license type, but most providers do have a community residential license when we brought that new license on in 2014. And so we are just making a correction here to make it clear that providers who serve both children and adults with disabilities are eligible for that dual residential setting and child foster care license. So we want to make sure that that settings that are serving people with those high medical needs are able to, children are able to live there as they age out of foster care and transition into CRS, community residential. All right, and then moving to section 17. So this is beginning on page 15, starting at line 20. This is making technical changes to HCBS provider standards. So in 2019, we moved forward an initiative to kind of streamline and modify and simplify our waiver services names. We had services that were doing the same thing on the DD waiver, but called something different on the CADI, CAC, or BI waiver. And so we made a lot of name changes, and those have all been implemented since then. And so this is just updating some of those names in Chapter 245D in our provider standards chapter. And then section 18, page 18, line 28. So this is a follow-up from last session regarding SUD treatment providers and being able to provide guest speakers in those treatment settings. And so we're appreciative of the legislature's passage of that. We do want to make sure that if there were to be some kind of investigation around the use of guest speakers, that providers are able to document when they're using those guest speakers. And really, we think these are just some minimal documentation requirements so that if some kind of investigation happens, that providers have that in their file and they're able to reference back to this is what happened and those are the services that were being provided. And then moving to section 19, page 19, line 21. So this is removing a screening requirement for people on the DD waiver who are accessing HCBS services when they're leaving regional treatment centers. So I think it was 2021, the legislature passed a provision that was led by mental health advocates, by NAMI in particular, that would allow people when they were in an institution, like a hospital, for example, or an IRT setting, to be able to keep their waiver open for 21 days while they were in that institution so that when it was time for them to transition back to the community, they didn't have to necessarily jump through hoops and get a new Min-Choices assessment unless they had some kind of change in condition. And so that has been implemented since then. Really appreciative of that, and hopefully it's helping with the hospital decompression. But there's a particular requirement for people on DD where they have to actually, it's not as streamlined. They have to meet with the screening team before they leave. And so this is just removing that screening team requirement so that people can transition back to the community. And that's, I should say, a couple of sections. So it's section 19 and section 25 in the bill. Section 20 is just removing the expiration date for the American Indian Advisory Council. So this is a council that's been around since 1984. It's not going anywhere. They provide important guidance to the department and to the governor on substance use disorder and other behavioral health policy recommendations. And so this is just removing that expiration date altogether from statute. Section 21 is related to what's called freestanding room and board for substance use disorder providers. So this is a room and board that is often offered in combination with an intensive treatment, outpatient treatment. It was initially started when providers in greater Minnesota were oftentimes not able to find, people weren't able to find residential settings where they could both live there and get treatment. And so there are these programs that have housing associated with intensive outpatient treatment. And one of the complications, given the workforce, is that people aren't at the settings typically during the day because they're in treatment for most of the day. But there are requirements around staffing at those settings. And so this is just making a change that when residents who live in that program aren't present, the staff don't need to be there. There has to be a staffing plan in place in case they come back, but that's just a flexibility that we think makes a lot of sense. Section 22 starting on page 22, I believe, is related to our family substance use disorder treatment program. So there are treatment programs that serve families, so people with their children, and we pay them an enhanced rate in order to be able to provide those important services. Something we definitely need more of, so hopefully we'll continue conversation on these settings throughout session. But this is really changing a limitation around the provision of daycare at those settings. So when one of those treatment settings is a licensed daycare facility, I believe they can provide as much daycare as needed. But when they're not, they are limited to 3 hours of daycare a day, which is not necessarily sufficient. It's typically not sufficient for the hours that someone needs to be in treatment, getting access to the services that they need to heal and be a good parent. So this is removing that requirement and making sure that daycare can be provided. There's still all kinds of licensing requirements and safety requirements in these settings. Section 23, beginning at page 25, is related to our home and community-based services culture of safety pilot. So this is a provision that might look familiar from last year for members who were here. So this is a current pilot that we collaborate with, I think, about 8 counties on. And this is really taking a step back when we think about critical incidents in 245D, so home and community-based services settings. And it's not replacing a licensing action or some kind of legal action or maltreatment action, but it's really taking a step back and understanding when there was a critical incident, so when there was a medication error, when someone fell asleep on the job, when there was an elopement, why did that happen from a systemic perspective? How can we map out that whole incident and really understand how our laws and policies and just system as a whole contributed to that incident versus, saying, well, a worker did something wrong, and so now we're going to punish them, now we're going to fire them, and then really leaving the provider in a position where it's hard to find workers. And there are times when there does need to be a service termination potentially, or an employment termination, but many times workers are doing the best they can within a complex system. And so these are opportunities for us to, they're voluntary opportunities for providers and counties to work with us on some of these critical incidents and really assess them from a more holistic perspective. This is a kind of safety science that's used in other industries. So hospitals use this kind of approach, as does the airline industry, and it's actually proven to lead to safer outcomes for people and more accountability. So this is a provision that will codify the HCBS Culture of Safety program in statute, similar to the codification that we have for our children and families critical incident process. And then it will also provide some protections around making sure that when people do participate, that they can say things of their opinion, maybe not necessarily facts, that wouldn't be admissible in other venues like a criminal or civil action. So this is something that will go through judiciary as well this year. Section 24, page 27, line 13, just updating a cross-reference. Section 26, because I already covered section 25 in a previous overview. Section 26 is removing the expiration date from the state traumatic brain injury program. This has been around since 1992. So again, this is a really important advisory council that I think every other year provides recommendations to the department and lets us know how we need to do better to serve people with traumatic brain injuries. So wanting to make sure that their work continues. Section 27, beginning on page 30, line 26. So this is related to a couple policy changes to really comply with our informed choice community living policy under Medicaid law. And so first of all, there's kind of a clarification. So this is clarifying the definition of community living settings under our disability waivers by defining a provider's direct and indirect financial interest. So that makes a difference as to whether the service is being provided in a person's own home or a provider-controlled setting, either of which is fine depending on what the person chooses, but we just need to be really clear about what services are allowed and being provided in those homes. So a lot of the language in these sections looks new, but it's moving things over from another area of statute that's existing law. in part because we missed applicability of the community living definition in Chapter 256B092, which is the developmental disabilities waiver area. Instead, we just had it in the CADI, CAC, and brain injury waiver area. So we're consolidating those definitions into one area so it looks like a lot, and really clarifying those definitions, which are an existing policy right now, and as well as our waiver plans, I believe. So we want to make sure that that providers are very clear on what those definitions mean and that they aren't liable for any kind of fraud or other issues if there was a lack of understanding there. Section 28 and 29. This is just making some updates around the corporate foster care and community residential setting closure statute. So it's deleting a contract requirement between DHS and counties of financial responsibility and the license holder, because we already have a policy where all of those people have a form that they agree to this contract, so we don't really need a statutory requirement. So there's already an administrative process in policy. We were directed to do that by the legislature, so that lives in the community-based services manual. And so this is just sort of a duplicative requirement that we're simplifying and removing from statute. Section 30, beginning on page 35, line 28. So this is another technical clarification in Chapter 256S, so our elderly waiver statute. So this is related to the recodification for elderly waiver statute that happened, I think, back in 2019. When we did that, there was a remnant of a piece of information that got left where it shouldn't. And so this is just clarifying that. It's an obsolete reference that no longer makes sense. Section 31 and 32, these are changes related to ABLE accounts. So for members that might not know, ABLE accounts are tax exempt. I'm not sure if I'm using the right word now that I'm sitting here. Accounts for people with disabilities so that they can save money without being with their benefits, being able to maintain their benefits. And so this is a federal allowance that the IRS issues guidance on. And so every so often we get updated guidance from the IRS. And recently they've updated some of their guidance around how guardians for people with disabilities or older adults can interact with these ABLE accounts. And they do allow guardians to be able to interact and open accounts for people. But our state law does not allow for that. And so we're making a change to align with the IRS guidance here. There are some people that, it's my understanding, have went and opened up an account and put money in it, but now the guardian doesn't have access to it under law. And so this is an important change to make sure that people can continue to save and use those accounts to their advantage. Sections 33 through 37 are technical effective date corrections. So many members might be familiar that sometimes we err on the side of caution when we put a federal contingent effective date in statute, because we oftentimes do need federal approval for changes from the Centers for Medicare and Medicaid Services, but sometimes we're not quite sure if we do. Sometimes there's more than one way to look at our state plan agreements or waiver plan agreements, and at the end of the day, there might be an efficiency that we can take and not have to get federal approval. And so that happens occasionally. It has over the year. This year, we've been told that there's been a few provisions. So there's, I think, 5 different subdivisions in these sections where we didn't need federal approval. And when we communicated that to the revisor, they had indicated that we would need to go back and amend session law around federal approval in order to remove the notes from statute that the revisor put on there about pending federal approval. So this is really just something that we were advised to bring forward by the revisor. Section 38, which is the final section, I believe, is a repealer. So 254B13, subdivisions 1, 2, 2A, 4, 5, 6, 7, and 8. This is a SUD Navigator pilot program that's no longer operating. Chapter 254B16, another similar pilot project that I believe we never got federal approval for, so was never even in existence, at least in practice. 256B 49 subdivision 23, that's related to those provider definitions of direct and indirect financial interest, where we moved them out of 256B.49, and we're moving them instead to, I think, 256B.493. So we're not losing that language, we're just moving it somewhere else. And then chapter 260.835 subdivision 2 is removing the expiration date for the child welfare, American Indian Child Welfare Advisory Council.
Okay, that's a lot right there. Before we go to questions, I do have a testifier. So I'd like to call the testifier up. We have Josh Berg. If you'd like to come forward, introduce yourself and who you're with. Welcome to the committee. Please introduce yourself and start your testimony.
Thank you, Mr. Chair and members. My name is Josh Berg, he, him pronouns, and I am with a nonprofit called Accessible Space. We are based here in St. Paul and provide affordable, accessible housing for individuals with disabilities, brain injuries, seniors, veterans across Minnesota, as well as upwards of almost 30 states across the nation as well. Thanks for allowing me to testify here today. I know this is informational only, but I figured I could plant some seeds as well and come back as needed for future hearings with some of these sections. As I mentioned, we provide affordable, accessible housing for individuals with disabilities. All of our individuals are very low income or extremely low income. All of our communities are HUD communities. We provide community residential services, the typical 4-bed group homes in residential settings. We provide integrated community support services, which is I guess the easiest way to say it is the replacement of customized living for those folks under 55 receiving CADI and BI in apartment settings across the state. And we provide some IHS services as well to folks living in their own apartments or homes. Several of you have settings in or have communities of ours in your settings. Representative Curran, Finke, Hansen, and Hicks, we have communities in all of your settings. So anytime you want to reach out or need some insight, I'm happy to connect. I just wanted to comment on a couple of the sections and reinforce the significance of using any and all appropriate flexibility you all have or can direct towards the department in these unprecedented times. As you all know, we are in a massive workforce crisis, and we are trying to solve the long-term care compression issue. I know you'll hear hospital decompression and that stuff. I just wanted to broaden that out a bit too. It's not just the hospitals. They're just finally speaking up and feeling the pain. We've been feeling it in the post-acute side, in the long-term care side for many, many, many years. It's unfortunate that they're feeling it, but now that they are, it seems like it's a topic that's finally being discussed. So just wanted to call that out. We must continue to encourage and allow creative strategies that focus on supporting individuals with disabilities, seniors, those with brain injuries, to be able to live their lives how they want and where they want. And that's the very person-centeredness that I think we're all here to support. I would also like to take a moment and thank the department, specifically Ms. Grom, and the Assistant Commissioner, Natasha Mers, and their team for looking at a specific DHS policy that would immediately address some significant barriers that are not allowing low-income individuals with disabilities and brain injuries to find permanent, accessible, and supported housing outside the hospital and nursing homes where they're currently stuck. The issue I'd like to call out is related to the licensing moratorium that Ms. Grom talked about in section 14. And it's complicated a little bit by the fact of the HCBS settings rule that's also in effect that we're working with. And I'm specifically referring to a DHS policy issue that disproportionately impacts customized living settings that are exempt from AL licensure, formerly had the Housing with Services designation, and that primarily or completely serve individuals on the MA waiver. These settings are prohibited from transitioning to the new Integrated Community Support Service, and they're also too big to fall into the CRS setting. So most of our sites are 6 units or 8 units, so they don't fall within the typical approved 4-bed group home settings. The department continues to enforce, in my opinion, a completely arbitrary and DHS-created, not CMS-directed, 25% limitation or cap on the number of individuals who are able to receive these supportive services in these settings, even when those are the services they would like to receive. So in other words, regardless if a person wants to live in one of these settings that they completely qualify for, qualify to live in per HUD's guidelines and requirements, and even though the setting can appropriately meet their needs to support the client, which again, they are choosing those services, and in spite of the fact that these settings, in ASI's case, have staffing available to actually meet their needs and move them in immediately, we're being told we cannot do that and it cannot be approved. So I'm confident that we will be able to work through this with the department and get through whether it's a legislative action or amendment to this potential bill or another one. But I just wanted to raise that as a really simple, in my brain, policy solution that could help alleviate some of the compression issues right off the bat. Finally, while there are many other proposals working their way through the process that impact ASI's ability and other organizations that serve low-income individuals with disabilities and seniors, such as appropriately including nursing time and services within the ICS framework, looking at capping the supplemental nursing staffing agency rates for healthcare facilities beyond just those in skilled nursing facilities, and I just encourage you all to consider the ideas you're hearing and weigh them against the day-to-day challenges that our organizations are facing. After learning a bit more about the critical incident review process as outlined in this language, I mean, this is awesome. I mean, this is something that could result in some really positive long-term outcomes and really look at how we do the survey and inspection process differently. For those of you that I don't know, I used to work for the Department of Health and oversaw the home care and assisted living program there. So all the licenses and surveys and stuff of assisted living providers. This approach looks beyond just the enforcement, the dropping of the hammer, the figuring out who the bad actor was. So I commend DHS for this language proposal and fully support it and hope you guys will as well. Representative Baker, you and I chatted a couple weeks ago after a hearing about just how broken the survey process is at times within MDH when we're looking at assisted livings and SNFs. And I really think that this could be something that could be broadened out across other regulatory agencies as well. So we know what our immediate challenges are, and they include keeping the lights on so more individuals don't end up in the hospital or long-term care settings unnecessarily, finding and retaining qualified and caring individuals to provide care throughout Minnesota to our most vulnerable individuals, and fixing the system to make sure all the costs are reflected in the frameworks that support the low-income and vulnerable individuals we serve, and finding ways to remove the unnecessary barriers preventing individuals from living in HCBS settings versus being stuck in hospitals and long-term care facilities. Thanks again for your time, and I'm sure I'll see you again in the future.
Very good. If you'd like to hang on there, I know the Chair Noor has a question for you. Chair Noor.
Thank you, Mr. Chair. I think you touched some few important aspects of the ICS and how, some of the components of people moving from AL to ICS. You also talked about the 25%, and I know under the site review that can be expanded through the department. The question that I have for you is, we understand the challenges that are going on, and also lack of providing the nursing component in terms of when you're doing ICS. How can we solve that problem so that it's a seamless transition from AL licensure to the ICS? At the same time, I think we know that we're still struggling with the 245D licensure. Many people are still waiting for. Can you explain, elaborate? I know you touched a little bit about those issues.
Mr. Berg.
Yeah, Mr. Chair and Representative Noor. Yes, no, so to clarify a couple points. So there is, I'll speak on what ASI went through during the process. So we transitioned 8 of our formerly customized living settings, apartment settings, to ICS. Through customized living, we were reimbursed for nursing for all the cares that we were being provided through the assessments that are approved by the case managers through their SAs and 6790s and that whole process. So we were able to provide nursing through that framework. Once we made the transition to ICS, that all disappeared. And so we could essentially make the choice of not providing those nursing services anymore because they're no longer being reimbursed. However, we know best practice. The the acuity level of the clients that we serve, we can't just stop providing nursing. So currently, we're eating those costs, and we will continue to do that, knowing how important and critical this service is to our residents, many of which we do bowel programs, they're quads, we do all hands on deck ADL support, medications, trachs, ostomies. I mean, we serve very complex individuals, and we can't just end our services. So I've applied for a few grants to try to see if we could buy some time and do that. I'll circle back to the 25% thing too. So the 25% really is specific to ICS and going through that. The settings that I'm talking about that are really stuck are those customized living settings that are exempt from assisted living and, like I said, can't transition to ICS. So we have a home in Minneapolis, 2 homes in Minneapolis, both are 6 units, side by side 3 units, that because they have shared spaces, they don't have their own individual bathroom, they don't have their own kitchen, we can't move them over to ICS. So that's where we could potentially get a higher than 25% number. But because they're customized living and with the language that was just put in a year or 2 ago to put the moratorium on customized living providers serving folks under 55, we're stuck now. And I have 3 open units in Minneapolis with folks living in hospitals right now ready to move in, but I can't approve them for the 24/7 services because I don't think we're going to get paid for them until they turn 55. So that's the challenge we're in right now.
Thank you, Mr. Berg. Chair Noor.
Thank you. Thank you for that clarifying statement. And I know as we are thinking about transitioning those who are serving less than 4 residents to the CRS program, we also need to be thinking about those other smaller settings whereby they don't have, key that they can give individual into a single unit as we think about how to serve more individuals in a different setting, especially those who transition to the AL and they don't qualify because they're serving individuals who are less than age 55. So that's a conversation that we need to have and to find a way. But also you spoke about eating the cost. So if an individual cannot pay, for example, they don't have housing support program, maybe they're receiving other income and they don't want to pay for the rent. How is that captured through the ICS model?
Mr. Berg.
Mr. Chair, Representative Noor. So at ASI, because all of our settings are HUD settings, they all, it's governed by HUD. So my view, my lens is with services because our property management team vets and goes through all the applications for all the housing. So anybody that applies, if they qualify based on a permanent physical disability, meeting the financial requirements, and they qualify otherwise to live in that home or that apartment, they can live there. Now, our property management team then will work with them, and in these settings, they pay up to 30% of their income, and HUD subsidizes the rest, separate from the services side. And then all of our folks receive services. I don't think we have a single private pay person, so all of our folks receive services through CADI and BI and are reimbursed that way. Now, obviously, there's challenges related to processing SAs and 6790s timely and working with the counties who are also short-staffed and the technical issues that may or may not be happening with the department and other areas. So we really, we're not looking to move people in and out really quickly. I mean, we're there to support them. HUD does a good job of working with us, our property management side, and working with the residents to make sure that all of that is going well. And, if it's a service-related thing, I mean, we still have folks that we provided services last January that we haven't been paid for from the county or DHS for a variety of different reasons that we're working through, that we will eventually lose that money if we can't get it extended beyond the 12-month timeline that we may be able to go back and collect retroactively. So it's a struggle.
Okay. Thank you, Mr. Berg. Chair Noor.
Thank you, Mr. Chair. I think there's a lot of work that needs to be done. I appreciate you coming, so hopefully we can get it done through this session. Thanks.
Yeah, you're welcome. All right. Thank you, Mr. Berg. I have a list of folks here. I have Representative Hicks, Baker, Noor, and Karan. So we'll start off with Representative Hicks.
Thank you so much, Chair. Thank you so much for bringing this for us to preview. There's a lot to take in, so it's nice to take a look at it in advance. I did want to just kind of follow up on subdivision 12, line 25.3, where we're talking about Department of Human Services Systematic Critical Incidents Review Team. So culture of safety has really been wonderful, I think, for the disability community for a variety of reasons, right? Really, taking what we know has worked in other sectors and bringing it into our world. But I do have some questions around where we talk about the actors that may be involved and who could be involved. I like that it's voluntary, I like that it's optional, but one of the things that has always frustrated me about critical incidents review and these cross collaborations is the lack of the actual funding and time for people to do the work. And so this is great, but if it's just being added onto the workforce, added on to what these organizations and these agencies are already doing, without the funding to sort of allow that to really be a focus, and not just within the department, but I see OMHDDs on here, I see we've got health in here, we're allowing community advocates, to join, which is great. We need all of those people at the table to really do this work well, but how do we financially support that work so we're not just piling on more responsibility to folks that, as we've heard over and over again, are already overworked, understaffed, and feeling the pinch?
Representative Graham.
Mr.
Excuse me,
Chair,
Director Graham.
I'll take it.
Kind of a representative right now, I don't know.
Mr. Chair, Representative Hicks, thank you for the question. So, I think we totally agree that we need some funding, particularly if we're going to codify this. We really would. Right now, it's a pilot, it's limited, and it is voluntary. So people don't have to participate if they don't want to, so there's that. But we would like to make this a more permanent and expanded option, and that is something that we have in the governor's budget recommendations, administrative resources, in our HCBS workforce sustainability package, because this is also a workforce retention strategy. So making sure that people feel supported at work, that they're not necessarily getting fired for things that weren't their fault or that they couldn't do anything about. And so we are seeking funding for that purpose.
Okay. Representative Hicks.
Thank you, Chair, and thank you for that. Members, I just think that we need to be mindful that this extends past the department. So when we talk about funding, we need to make sure that we're funding OMHGD. We need to make sure that the counties have what they need. We need to make sure that we're allowing everyone that's on this list of people that might participate to have the ability to truly participate. Because if we just keep piling it on people as here's this great thing that will make it better, but we're not going to give you any resources or time to attend these things and to do that work, then it's not really going to move us forward. And so members, I'd encourage us to kind of keep that in the back of our minds. This goes beyond the department, so that when we're having these conversations about this moving forward, we're making our budget recommendations and having those conversations, that we're really making sure that it's a broader recommendation. Thank you so much.
Thank you, Representative Hicks. Next, we'll go to Representative Baker.
Thank you, Mr. Chair, and Ms. Gom, thank you for bringing this technical bill forward. Representative Edelson, every time I see these kind of bills, and there's a lot of them that are technical and fixed, and I know sometimes we as members don't get every piece of this. So my question really to DHS today is there anything in this technical fix that makes it harder to employ somebody or to keep them? Are we making things harder to license folks, or to put more burdens on our operators in any stretch of the imagination? I know you mentioned something about you're cleaning up something with duplicative licensing requirements, and I'm not sure you caught my ear on that, and I'm like, wait a minute, what does that mean? Because what we're hearing and what we all know, like to Representative Hicks's comment, we need the dollars to do this, but we also need less licensing, or less, I'm not saying less oversight, but smarter and more efficient. And we have got to think about the operators here running our homes and that kind of thing. So I want to make sure, as you look at this whole thing, with some of the questions and the changes that you've made in some of the chapters and the rules, are there things that are going to make it harder for operators to employ people?
Director Graham.
Mr. Chair, Representative Baker, thank you for that question. I think it's an important one. I will say, I am not aware of anything in this bill that's going to make it more challenging for people to employ anyone. I'd certainly be open to conversations if that's something that people are hearing. But really, this bill, the approach is to remove things that are duplicative, to remove things that are kind of hanging out in statute that don't need to be there, that where we already have a policy for it, for example. And so that's really been the directive that we've got from our leadership at the department, from Commissioner Harpstead, is looking at what can we subtract and what can we simplify. We know that there are, elements of regulation that we need for health and safety, and we do need those things, and we can't remove everything, but there is a lot that is duplicative or not necessarily adding value to the system. So we really are trying, by and large, with this bill to address that. I will say, beyond this bill, and in the SUD space in particular, we've really taken the feedback that we've heard from you, Representative Baker, and Representative Fredericks from the SUD community around regulations that don't add value. And so you'll be seeing some of those in our upcoming bills moving forward this session, and the governor's budget recommendations in that segment as well, of really trying to simplify and make things easier for people.
Representative Baker.
Thank you, Mr. Chair. And one follow-up, and I think this is more of a reminder to all members with any committee that we serve on. As we have heard, every single committee deals with workforce shortages and issues and the money that we need. Let's always keep asking our agencies, is this making it harder or is it making it easier for our operators to function? And again, nobody wants to give up safety guards, but sometimes those safety guards are overly built, and we haven't had a chance to actually step back and look at them in a way that makes sense, because our operators also have a lot of liability there too. We can't solve it all with government rules and regulations. I just want to keep reminding us as we move through this. You also, my final comment is you mentioned a couple of the advisory councils that you're updating, just with really dates, simple updates here. And, obviously advisory council got my eye in my ear. I don't think you're dealing with anything to do with the ORAC council here, which is, again, for members, that's the Opioid Epidemic Advisory Council. I'm very involved in that council and the good work that we've done around the state. I know the governor has made some changes to our council that he's suggesting this year, and I have grave concerns about those changes and what they're going to look like. I don't think you're suggesting anything in this bill here, Representative Edelson, or the proposed bill, but I do want to just give members a heads up that watch the advisory councils and what the changes are that are coming. They're not always what the advisory councils want, and we have to make sure that we vet those things out properly. I'm looking forward to more conversations about that as it comes our way, but I just want, again, maybe to Ms. Gom, there is nothing in here about any other councils that you've mentioned except what you mentioned earlier with the 3 councils, correct?
Director Graham.
Mr. Chair, Representative Baker, that's correct. There's just 3 councils, and we've simply removed the expiration date from law. They were going to be expiring at the end of this June, and so we want to make sure they can continue.
Representative Baker.
Just a little advertising for the ORAC, that was all. Thank you. I love the council, thank you.
Thank you, Representative Baker. Next, Chair Nord, did you have further questions?
Thank you, Mr. Chair. Yes, we look forward to having more conversation on the ORAC. Probably I'll be thinking about removing the sunset on that. We'll have more conversation. Thank you, Mr. Chair. I think the question that I have is addressing the culture of safety pilot program. As we understand, there's always incidents and also fines that are associated with assisted living, licensure, or any home and community-based services. Will this reduce some of those findings and also reduce the fines that we end up charging? I know it's the Department of Health, which controls some of the other licensing. How will that interact with what's happening at the Department of Health?
Director Graham.
Mr. Chair, Representative Noor, that's another great question. So this kind of model, this kind of culture of safety does have research associated with it that it does make systems safer. So to the extent that we continue working with these kinds of models and expanding them and getting the funding that we need to do that, both at the Department of Human Services and at MDH, who I'm told has recently started using this model as well for some of their settings, I do think that there's a potential that incidents might decrease as we really understand what are the issues in the system, in our policies, and our procedures, that we can fix ourselves and make things safer for the community. And then just to be clear, this particular critical incident study is just for 245D settings in this bill.
Chair Nor.
Thank you, Mr. Chair. I know we talked a lot about state plan. I know for everybody else, we use acronym on so many other things. If you wanted to touch a little bit, what is state plan so people are aware of in general? Thank you,
Director Graham.
Mr. Chair.
Mr. Chair, Representative Noor, it's probably not totally my expertise here, but the state plan agreement is an agreement that we have, the Department of Human Services has with the Centers for Medicare and Medicaid Services. And it just outlines all of our benefits that we offer under our medical assistance program. And so it's kind of the core set of services that we provide and that we fund in our program that people are eligible for. There are other kinds of plans that you hear about, like a waiver plan, for example. And so that's a little bit kind of a different kind of plan where there's different eligibility requirements, and there are things that aren't necessarily covered for all populations, like the state plan is, but maybe for people with disabilities or older adults, they have some functional needs where they need an additional layer of covered services. And so that's sort of the distinction between some of our waiver plans and our kind of core state plan agreement with CMS.
Chair Nor.
Thank you, Mr. Chair. Thank you.
Next, we have Chair Karan. Representative Karan.
You've been promoted.
Thank you, Chair. And Director Grom, I just have a question for you. This is page 31 at the top regarding the definition of community living setting. Can you clarify for me? I know under a 245D licensed facility, we refer to them as community residential settings. And I say this because the community living setting, of course, it's a very similar phrase, which we know happens in DHS a lot. But it specifically states that the community living setting is not owned by the service provider, but I know that community residential settings are often owned by the service provider. So can you just clarify for me, are those two distinct definitions that we're looking at?
Director Graham.
Mr. Chair, Representative, yes, those are two distinct definitions. So this is really it's a definition around essentially aligning with that these are settings that are a person's own home. They're not a provider-controlled setting. And so we want to make that really clear because different services are allowed in different settings, and people want to live in different kinds of settings. People want to live in a provider-controlled group home or an integrated community support setting, and then many other folks want to live a little bit more independently in their own home and bring in their own providers of choice to support them in those settings.
Representative Karan.
Thank you.
Okay, any other comments, questions? I'm not seeing anything. Representative Edelson, thank you for bringing these forward. Director Graham, thanks for being here today to walk through everything for us and help answer some of our initial questions. Looking forward to the continuing work. It sounds like there'll probably be an amendment or two we'll see on some of these bills as they come forward. This covers everything that we were planning on for today. We will be having several bills coming before us on Wednesday. We'll be hearing House File 732, which is the accountable asset limit in housing supports. We'll be hearing House File 905, which is non-residential mental health services authorizing for minors. And then there's going to be two more technical bills from DHS because we didn't get enough of them today. We'll have a couple more on Wednesday. So I want to say thank you everyone for being here today. Thanks for the comments and questions. And with that, we're adjourned.